For today's webinar, we have Brad Duncan, who is with NorCal Group. He is a senior risk management specialist, and he's there for 27 years. Prior to that time, he was affiliated with a hospital professional liability carrier based in Richmond. Brad received his undergraduate Bachelor of Arts degree from College of William and Mary in Virginia, and his master's degree in healthcare administration from Medical College of Virginia, as well in Richmond. Been in risk management for the past 30 years. And so let me go ahead and turn over to Brad and let him get started.
All right, thank you very much, Richard. And thank you, yes, well, I'll be having assistance in terms of the slide transition. And welcome to today's webinar, the physician-patient relationship. We can go to the next slide. Just wanted to review with everybody that this is a 1-hour CME program, and we will be having instructions at the end of the program for you to be able to access and obtain the CME certificate at the conclusion of the program. It's very easy to do. Go ahead. Just a disclaimer in general, I am a risk management specialist. I'm not an attorney. The information that I provide or information in this presentation is not legal advice. If legal advice is needed, it's a standard thing that we obtain the consultation of an attorney. Go ahead. Nope, that's me, just the faculty. Just a little bit of background. We on an ongoing basis, as many of you know, we develop CME educational programs throughout the year. We have webinar series that are available for our policyholders and also when working with our partner medical societies. So thank you. Go ahead. All right, well, let's get into the program today. And again, everybody, thank you for taking time out of your busy schedule today to attend this webinar. I do hope that it is something that will be of great value to you, because I think in planning this, and I remember having conversations with Richard, this is something that I believe he and the society often get questions about, the physician-patient relationship, in particular, termination of the relationship. In addition, that's something that probably when I look at my call logs and my colleagues at NorCal, a majority of the questions have to do with the physician-patient relationship. So it's very important and timely with respect to, and it's an ongoing issue that, I've been dealing with for 30 years. So I imagine the reason all of you are here, because this is such an important topic, I'm sure nearly every one of you have felt the need to terminate a patient from your practice at some point. So with this in mind, let's take a quick look at the plan for the presentation and objectives we're going to work with to achieve. I'm going to begin with the establishment of the physician-patient relationship and give you some tools to assess your practice for related risk exposures. I'll review some methods appropriately to terminate the physician-patient relationship and thereby mitigate issues. And then finally, I'll discuss abandonment and address risk management best practices to reduce medical professional liability claims related to allegations of abandonment. So there'll be some good takeaways through this program. On to the next slide. So let's begin with the establishment of the physician-patient relationship. This is the point at which the relationship is established, and it's not always clear or absolute. It really depends on the specific facts of each situation on a case-by-case basis. However, I can say it usually begins when the patient sees the physician and the physician accepts the patient for diagnosis or treatment. Now, in some jurisdictions, it may be established when a physician agrees to treat the patient for a face-to-face interaction may not be necessary. In some instances, you can establish that relationship just by scheduling an appointment. And obviously, this has been something that's been very important in the last several months when many of you are seeing your patients via telemedicine, telehealth, and you don't set up a face-to-face meeting, but that relationship is established virtually, from that standpoint. But again, even so, many of those same situations still apply. The physician-patient relationship can be created when a physician exercises medical judgment in a situation in which the patient would reasonably rely on the physician's advice. Next slide. Now, generally speaking, a physician-patient relationship is formed when a physician affirmatively acts in a patient's case. And this can be by several actions listed on the slide: examining a patient, recommending treatment, prescribing medication, diagnosing, or agreeing to do so. Now, do you think giving your sister's friend some telephone or email medical advice establishes a relationship? Well, it is likely that a physician-patient relationship may have been established in that situation. Informal consultations can create a physician-patient relationship if the recipient depends upon the medical advice given to determine patient management. Now, NORCAL has information regarding formal and informal consultations, and that's included in our resource document at the end of the program. So you'll be able to access some of that information in the future as well. And that's under physician-patient relationship, establishing and terminating the relationship. Now, a physician-patient relationship can be limited to a specific time, place, and purpose. Examples of a limited relationship include employment physicals, workers' compensation exams, follow-up care provided by a hospital's on-call physicians after patient discharge, and when a patient presents to an urgent care clinic where no appointment is needed. Now, an emergency room encounter might appear limited, but physicians need to be cautious since these encounters could involve some follow-up, extending the encounter beyond the time spent with the patient in the ER. It should be made clear through handoff communication when the ER physician's role has ended. And again, often there are situations I'm aware of that come up when a patient's discharged from the ER and there are pending test results that need to be followed up on or communicated with the patient. Let's go to the next slide. And here we're going to be dealing with an angry, disruptive, and loud patient. This is ZUZU, case number 1. Let's discuss some situations that might make you wonder whether you have established a relationship. ZUZU is a 50-year-old female with a rare condition called myomoma, and that's hard to say, in which the internal carotid arteries that supply blood to the brain become narrowed. She had surgery about 20 years ago by a world-renowned neurosurgeon that is no longer in practice. ZUZU recently had a stroke related to the myomoma, and her PCP referred her to a new neurologist. ZUZU's appointment is scheduled for 1 p.m. At 1:15, ZUZU becomes extremely restless and irritable and very loudly complains to her husband about the wait. Next slide, please. Her husband steps up to the reception desk and waits for someone to acknowledge him. No one does. He clears his throat and says, "Excuse me." The receptionist, without looking up at him, says, "The doctor's running behind. Have a seat until you're called." Next slide. The minutes tick by and ZUZU becomes, the minutes tick by and ZUZU begins to feel dismissed and unwelcome and is making sure everyone around her knows how she feels. She is tired of being ignored. She continues to complain loudly, becoming more and more agitated, demanding to be seen. Her actions upset the receptionist, disrupt other waiting patients, and the physician, hearing what is going on from the back, now refuses to see her. ZUZU's husband calms her down. The receptionist noticed that they had signed in initially and then sat down in the waiting room. She then recognizes that she did not complete the check-in process in the system, accounting for some of that delay. She also recognizes she did not make eye contact or acknowledge ZUZU's husband when he came up to inquire about the delay. The receptionist is flustered and upset because they have been waiting and were forgotten, but she knows bad behavior is never acceptable in their office. She also knows the patient expects to be seen at her scheduled appointment, but now the doctor refuses to see her. ZUZU clearly had an expectation to be seen for her clinical condition once she scheduled the appointment. Her PCP also had the expectation his patient would have the consultation needed and receive recommendations for further evaluation and treatment for her symptoms. So what do you think would happen if the neurologist refuses to see ZUZU? Has a relationship been established? Could refusing to see ZUZU at this point create a risk of abandonment? The receptionist isn't sure, so she calls her office manager to the front to help her decide what to do with ZUZU. And then the office manager calls NorCal and speaks to me. No, I'm just kidding. But in any way, in a busy practice, it can be extremely challenging to approach a situation with service recovery in mind and find out why a patient acts out. Next slide. As it was with ZUZU, the office manager brought ZUZU and her husband into a private room and asked her about how he could help. Still angry, ZUZU said her primary care physician insisted she come get evaluated by this neurologist, but she felt it was clear that no one here really wanted to see her, since she was ignored and kept waiting almost 30 minutes. The office manager apologized, relaying to her that the receptionist felt bad for her own actions that upset ZUZU and her husband, and that she forgot to complete the check-in process when she got busy. She wanted to be sure ZUZU understood it was her mistake and not intentional. The office manager relayed that the receptionist was also very sorry for not acknowledging her husband when he came back up to the desk. This quiet apology gave ZUZU and her husband an opportunity to calm down and acknowledge their own poor response to the situation. As the office manager took time and made eye contact and listened, he heard how ZUZU was the primary source of income for the household, and she felt sad, lost, and very afraid. Also, her primary care physician was concerned that ZUZU was exhibiting ongoing neurologic symptoms after the stroke, one of the reasons for her visit today. Together, they made a plan. The neurologist agreed to see ZUZU and to coordinate care with her primary care physician. ZUZU accepted the apology for the delay, and her husband agreed he would continue to bring her in for medical appointments and be sure they had recommended tests. Understandably, not every practice has time to take such actions in the midst of a crisis, but there are simple measures that practices can take to both ensure patients understand what to expect, as well as how to improve efficiency and patient satisfaction. Okay, next slide. So here are some recommendations. So let's look at some risk mitigation measures your practice can take. The attitude of your frontline staff can be very key in establishing a positive practice environment. First impressions really do make an impact, especially when it comes down to customer service perspective. I was so excited when I went shopping during senior hours and I was asked for my ID. Yes, I'm at that point in my life. And I thought, wow, first impressions. I don't look old, but of course my family and friends corrected that impression of me. When a patient approaches the reception desk, making eye contact, smiling, and looking interested sets the stage for positive patient experiences. Patients judge the efficiency of a healthcare practice and the competency of clinical staff by their initial personal interactions and how they are treated. They expect excellent care as a given, including service amenities such as courteous treatment and short waiting times. And they see that as a verification of high quality care. This just doesn't mean a face-to-face encounter. Think also about how a caller is treated. A welcoming, polite voice on the phone goes a long way. Even having a smile on your face when you pick up the phone helps in terms of setting the tone. Efficiency systems help to streamline patient throughout and support high quality perception. A few ways to do that include monitor the patient wait times and length of time that patients are kept on hold on the phone, ensure patients are apprised of changes in their appointment times, and given options if those times are overextended. One example is an office that has a whiteboard where the clinician names stating whether they're, it indicates to the patients in the waiting room whether they're on time or they're how far behind time they're running. And again, this just sets expectations. You could even give patients the power of choice. What would you like to wait, or would you prefer to reschedule, or if appropriate, see another provider? And that is all situational. Offering choices to your patients not only puts the power in their hands, but it also allows you to build a trusting and lasting relationship. So think what a difference it would have made for ZUZU if she was made aware of the delay and had been given a choice. Patients usually understand and accept that the patient before them needing more time during the appointment. In fact, they hope the physician would do the same for them. Standardize your communication workflows to improve effective handoff information and ensure a smooth running practice. Clear communication and sharing of patients' information, questions, or requests to and from the clinician give patients a sense their physician cares, is responsive, and is accessible. Now, I know from my own experience, it's very frustrating when I give my healthcare information and inquiries to the front desk or an MA, and then it doesn't get relayed or addressed by the physician. So that also can contribute to decreasing patient safety and communication. All these communication processes work together to improve the physician-patient relationship and patient satisfaction. This helps to improve patient adherence to their healthcare instruction and recommendations, and that ultimately improves healthcare outcomes. Next slide, please. A physician-patient relationship really depends on a firm foundation of mutual trust, and with that in mind, it is important to note that physicians have an obligation to care for patients until the relationship is appropriately ended. The AMA Code of Ethics opinion states that a physician has an ethical responsibility to place the patient's welfare above his or her own self-interest and obligation to others, and to advocate for the patient's welfare. Physicians who do not fulfill that obligation are at risk of being found negligent, possibly for a failure to diagnose or delay in a diagnosis allegation, and can be subject to discipline for abandonment. And I will discuss abandonment and withdrawal of care a little bit later in the program. But remember, building relationships of trust with patients is fundamental to ethical practice in medicine. Let's go to the next slide. So I want to begin with managing a relationship with the non-adherent patient. I'd like to make a distinction here between non-compliance and non-adherence. When a patient is non-compliant, they deliberately refuse to follow a treatment plan. A non-adherent patient unintentionally fails to follow a plan. Both non-adherence and non-compliance to treatment recommendations or office policies can be frustrating for physicians. Seeking solutions for these behaviors is beneficial for both physicians and their patients. Next slide. So here we have a case. This is the case of Clarence O. He's a 67-year-old retired male with multiple medical problems, including uncontrolled diabetes, coronary artery disease, and COPD. He has a history of smoking 2 packs of cigarettes a day for decades, no interest in quitting, and he does not exercise. Now, Clarence takes upwards of a dozen medications. He complains he's not feeling any better when he comes to office visits, but often cancels or no-shows for appointments. He has not followed up on consultations to specialists, and when questioned about his meds, it is apparent he is not taking his medication as frequently as directed, including his insulin. Next slide. You know, sometimes it's helpful to understand how these patient behaviors can push your buttons and affect your attitude and even feelings toward the patient. And then obviously being professionals, we have to kind of put some of those feelings aside, and sometimes even the bias we may have with respect to, you know, a difficult patient, and move forward in terms of the best interest for everybody. Now, a patient like Clarence, who is not regularly attending scheduled visits, not taking his medicine as directed, and seemingly not doing anything to help improve his own condition, can become a frustration, making you feel as if the patient is wasting your time. It may not be realistic to work on all the issues that Clarence has in one allotted visit time. Instead, identify what might be 1 or 2 important issues, such as understanding diabetes and the need for insulin compliance, or getting a cardiology workup. Like most patients, when Clarence began to understand his medical condition and the necessary treatment, it helped to engage him enough to lead to adherence. Patients who believe that their physician and the staff will allow them time to communicate their needs, their fears and complaints, and feel they're able to get answers to their questions tend to be more adherent patients. So you will want to collaborate with the patient, prioritize the medical problems, and begin or continue an effective treatment plan as a goal. It helps to try to understand the underlying causes for the patient's non-adherence. Sometimes you need to explore outside causes for behaviors. Clarence was asked about his own home situation. It soon became clear he was feeling overwhelmed with his wife's failing health and was paying more attention to her care than his own. Clarence agreed to referrals for outside support from home health and to ask a family member to help him with his wife. He began engaging in his own care plan, showing gradual improvement in diabetes control. He even cut back on smoking. Some good successes there. Next slide, please. So let's talk about some explanations for why patients may be non-adherent. In some cases, there's denial. When my father was living, for the longest time, he, didn't go to see a physician, didn't feel a need to do so. It wasn't until he actually ran into a particular problem and an emergency that he, did finally establish a relationship with a primary care physician. And after all that resistance, he was very happy that he did that. And it was a very good relationship. So there's denial in that situation. Sometimes there's cost. Lisa's medications and therapies are not covered by her insurance, and she has more out-of-pocket costs, which makes her less likely to buy the drugs or make treatment appointments. Then there's difficulty of the regimen. Brad has trouble following directions due to his memory problems and dementia. He forgets to get his prescription filled and sometimes forgets to pick it up. Now, according to the article, Why Patients Are Non-Compliant with Treatment, forgetfulness causes about a quarter of non-compliance cases. This becomes more of a problem with older patients and patients with cognitive difficulties or disabilities. Now, unpleasant outcomes or side effects of treatment. Julie is worried about the side effects and unpleasant taste of medicine, the prick of a needle, and the pain of physical therapy. In fact, Julie worries about everything, and that keeps her from following through. Lack of trust. Dan does not trust or believe that his treatment is going to make a difference in his health, and therefore he's not motivated to comply. And then apathy. Richard doesn't realize the importance of his treatment, and Jane doesn't care if the treatment works or not. They are both less likely to comply. And then previous experience. As in the case with Katie, who has difficulty sleeping and depression. In cases of chronic or repeat conditions, patients will sometimes decide that a treatment didn't work in the past, so they're reluctant or unwilling to try it again. Next slide, please. So before I begin talking about terminating a patient for non-adherence, I want to discuss the physician exploring whether a therapeutic alliance can be developed. Now, a therapeutic alliance refers to the personal bond between a physician and a patient where a partnership is made with the patient to achieve adherence to treatment. Next slide, please. Now, one risk management action you can take to manage a non-adherent or non-compliant patient is to attempt to form a therapeutic alliance. We know that behaviors can present in different ways. A patient can demonstrate treatment non-adherence. For example, you may notice that Dustin's blood pressure is not improving. Ask open-ended questions like, how's everything going with this medication? Follow up with Dustin. Are you having any problems with this medication? Go ahead and click that. So there's communication. Use plain language, even metaphors to explain a condition. For example, hypertension could be described as a garden hose under pressure. Another example is being clear to the patient and how to take their medication, since saying, take one tablet with food could be misinterpreted as taking 3 pills daily with each meal. So communicate with the patient and take a non-judgmental approach. Listening to what Dustin says can help make him feel more comfortable sharing and not feel he needs to please the doctor with his answer. Talk about the patient's stressors that may be impacting behavior and adherence, such as family or work or situations. Offer to discuss the patient's grievances. And if you can just go, why don't you just go ahead and click through the bullet points on that slide there, and then we'll be going through those. When educating patients, consider barriers to delivering healthcare information and educating the patient, which can include literacy, culture, language, and possibly psychological barriers. If you choose to attempt to rehabilitate your relationship with the patient, it should be done pursuant to office policy and protocol. And a patient may have frequent failed appointments, including no-shows or cancellations, and then consider having office policies and procedures to manage those. Now, there are several ways to address a continued problem with no-shows, and that's something that I get a lot of questions about as well. Institute same-day calls to reschedule, send reminder cards, and make reminder phone calls. Prepare a daily list of missed or failed appointments, which should be reviewed by the physician. You can also consider using warning letters and termination if no-shows continue. No-shows can be a red flag, and timely intervention is extremely important. Now, I recommend explaining your office policies up front. One way is to develop an office brochure or new patient packet. Include key information such as specialties, office hours, services offered, and even the practice's goals or philosophy for the patient care. You may include office expectations like keep all your scheduled appointments and provide 48 hours notice prior to cancellation, or participate in your care and treatment plan and let your doctor or the staff know about changes or concerns that affect your ability to follow our recommendations for your treatment. And we even have, that's something that's available as a resource, a sample practice brochure. And then collaborate. Collaborate with the patient by focusing on 3 things for a successful patient interview during a visit: what the doctor thinks the problem is, what the patient thinks the problem is, and each of their goals. The problems and goals may not be the same. Dustin tells the doctor the medication is causing headaches and dizziness and feels better when he doesn't take it. The doctor explains the danger in not taking medication to control his high blood pressure and therefore changes his medication. Ultimately, if the patient doesn't feel heard, they may not follow the doctor's suggestions. Okay, next slide, please. Now, it's important to formulate a treatment plan or patient contract that memorializes the expectations and patient agreement. Consider having a meeting with the patient to make sure there is a clear understanding of the condition, the treatment plan, and the consequences if not followed. Consider including a significant other, a caretaker, or an emergency contact, and that could be on a case-by-case basis and the situation of the patient. Now, in your agreement, clearly identify the patient's inappropriate behavior, actions, or inaction. Include a description of your expectations for future interactions with the patient and the consequences of the patient's failure to meet expectations up to and including termination of care. And one of the things I think oftentimes when I'm speaking with you and folks that call for advice in these areas is that, when there's difficulty, this is not something that just happened. I think that this is something that you recognize has been kind of brewing over time. And that's why it's really important to have this agreement and have these expectations set out so that it provides a guide for the patient and the physician. Now, the patient should sign and date the patient contract and be provided with a copy. Go ahead and click there. The document details in the patient's records, including who was there and how the information was received and whether the patient has accepted or rejected the plan. Communicate the plan and expectations to staff along with clear directions about how non-adherent behavior should be handled. Consider using a refusal of treatment, go ahead and click on there, form to document the patient's understanding of the risk and consequences involved in refusal. And lo and behold, NorCal also has a sample form available on my account for this purpose. Ideally, if an attempt to restore a therapeutic alliance fails and the decision to dismiss the patient moves forward, the record will contain clearly documented grounds for dismissal. And that information and documentation may be very helpful, obviously, down the road if there's any kind of complaint to the medical board or a malpractice claim. Next slide, please. Now, once a relationship has been established, a physician has a duty to provide care until it is no longer necessary, or the relationship is appropriately terminated by one of the parties. Now, a physician who does not fulfill the obligations is at risk of being found negligent or subject to discipline for abandonment. Patient abandonment decreases patient safety and increases physician liability. This happens when a patient is given the expectation that they will receive care and then is barred from receiving that care, which results in the patient suffering harm, and that causative factor is the barrier in receiving that care. And that's something that, when we're looking at malpractice claims, we always look for, what causation in terms of, is there something that we did or did not do that caused the bad outcome or the unanticipated outcome from that standpoint. Improper termination can result in a patient abandonment claim as well. Next slide, please. Now, abandonment occurs when a physician fails to provide necessary medical care to a current patient without adequate justification and or notice. Few abandonment lawsuits are filed because a physician terminated a patient relationship for improper reasons. In the great majority of cases, liability is premised on insufficient notice prior to termination during a time when the patient actively needs care. Now, let's discuss some example situations that may lead to an abandonment claim. Then we'll review some related NorCal closed claims. For example, number one, giving inadequate notice of patient termination is one example. Terminating a patient when there is no one available to take over care is another. Coverage inadequacies when the physician is ill, on vacation, treating other patients, or otherwise unavailable. This may be dependent upon your existing contracts. And closing your office or retirement. And that's one thing, you know, interestingly enough, as I look at my call trends, I've received a lot of calls during this pandemic period where many physicians have retired from practice because they have just decided, you know, with the pandemic and what have you, that this is the appropriate time. Maybe they were going to retire down the road or close their practice, and now they're facilitated the closing earlier as a result. So I've been on the phone a lot with folks regarding that issue. The issue of patient abandonment must be understood and considered before deciding to terminate the relationship with a patient. Next slide, please. Now, Mary is a 38-year-old pregnant patient with a history of second trimester pregnancy loss related to painless cervical dilation. She is scheduled for a cerclage with Dr. Push. After she was scheduled, Dr. Push discovered she had filed a lawsuit against her partner, Dr. Forceps, but took no action to start a termination process. Mary was admitted for surgery, and Dr. Push then informed her that she would not perform the procedure because Mary was suing Dr. Forceps. 4 days later, Mary had Dr. Stork perform the cerclage. However, she unfortunately miscarried. Mary sued Dr. Push, alleging the abandonment-related delay of the cerclage caused her miscarriage. Next slide, please. Now, acute conditions that warrant immediate treatment must first be resolved or stabilized before termination actions can commence. The American Medical Association Code of Medical Ethics Opinion 1.1.5 states, a physician's fiduciary responsibility to patients entails an obligation to support continuity of care for their patients. In addition, a physician must facilitate transfer of care when appropriate. Now, in this case, Dr. Push's duty to provide Mary with necessary medical treatment did not end when Mary filed a lawsuit against her partner. The court agreed with Mary in this case. Dr. Push had a right to withdraw from the case, but she had a duty to give Mary reasonable notice to enable her to secure another physician to complete the cerclage in a timely manner. In other words, Dr. Push needed to start the termination process much earlier and do so in a formalized manner. Next slide, please. So here are some risk management recommendations related to timely withdrawal of care. Consider the seriousness of the patient's condition. Do not dismiss patients with acute medical conditions. For example, a patient with an acute disease process, a surgical patient who may be experiencing post-op complications, a patient in active labor, latent pregnancy, or early in the postpartum period. Provide the patient with a reasonable period of time to obtain a subsequent provider. And as always, document these actions. Next slide, please. George is a 70-year-old married man who presented to the hospital with right upper quadrant abdominal pain, radiating to the right shoulder blade, nausea, vomiting, and fever. The admitting hospitalist ordered a surgical consult, and Dr. Potter, the general surgeon, scheduled George for a laparoscopic cholecystectomy that afternoon. He performed the surgery, and George was sent to the recovery room for an uneventful recovery. Dr. Potter left orders for George to be discharged once he took some sips of water and vitals were stable. He then left for a medical conference about 2 hours away, and Dr. Bailey, a gastroenterologist, agreed to cover for him. Now, George developed a drop in blood pressure, increased heart rate, restlessness, and abdominal pain, and the recovery room nurse noted that George's abdomen was firm and distended, indicating a possible bleed. The nurse contacted Dr. Bailey, who immediately came to see George. It was apparent that George needed an exploratory laparoscopic procedure, which Dr. Bailey was unqualified to perform. Now, another surgeon was not available in this small rural hospital. George was transferred to another hospital for surgery, causing a 4-hour delay. Dr. Gower at that other facility performed the surgery and contained the bleed, but George's recovery was prolonged and difficult. Next slide, please. Although coverage of the physician's on-call duties was arranged, George was essentially left without a physician competent to handle his surgical emergency. In other words, George had been abandoned. Inadequate coverage arrangements can lead to abandonment allegations anytime you're unavailable to your practice, and this includes circumstances like attending medical conferences. Appropriate coverage must be arranged. And of course, it was important in this particular example that the physician that was handed off to also had the requisite skills to deal with any complications. So let's go to the next slide. Let's discuss some risk management strategies related to coverage. Even if your coverage arrangements have been sufficient in the past, it's worth ensuring your current arrangements will not expose you to claims of patient abandonment if something unexpected occurs. Have coverage policies and procedures in place. Ensure the covering physician can offer your patients equivalent medical services. In the case of George, a gastroenterologist could not provide adequate coverage for a surgeon. Carefully discuss coverage details with the covering physician. Alert him or her to any unusual circumstances, including a list of patients who may need immediate treatment, post-op patients, those being worked up, or those in the middle of intensive treatment. Provide all entities where you have on-call duties and your answering service and your office staff with the name and contact information of your covering physician and the coverage time period. Inform your patients. Advise patients of the special call challenges and presented in rural settings, and ensure that they know what to do in an emergency when the office is closed and when you're otherwise unavailable. Document specific directions and advice given to the person covering for you. Again, always documentation, important. Next slide, please. Now we know that once a physician-patient relationship is established, the physician has an ongoing responsibility to the patient until the relationship is properly terminated. Terminating the relationship can be appropriate and ethical in a variety of circumstances. However, physicians need to be aware of constraints, as well as obligations and processes to use when terminating a relationship. So let's say you get to the point where discharging the patient seems to be your only alternative. And in many conversations I have, we kind of go through and exhaust all the scenarios and possibilities. And, now we've reached a point where maybe this relationship is not salvageable. How can you safely do this? Well, I'll review some steps to take. And I also want to mention here that NorCal, again, has resources and sample forms available on our website and my account to support the processes needed to terminate the physician-patient relationship. And again, there'll be contact information at the end of the program. I can be contacted for that information if you're interested in receiving that as well. Next slide, please. Now, if attempts to repair the relationship have been unsuccessful, it may be that your only choice is discharging the patient from your practice. First, let's review some examples of common reasons why a patient relationship might be terminated. Now, we've already discussed no-shows and cancellations, non-adherence and non-compliance, and initiation of legal proceedings or medical board inquiries as possible reasons for termination. Just back to that issue about legal proceedings, I have had situations where I was contacted by a physician who is being sued by a patient, but the patient says, I want to continue seeing you. Don't take the lawsuit personally. But that's just something I need to do. Well, again, that's something that you won't want to talk with. If you're insured by NorCal, you would talk with us about that, or you would talk with your carrier to talk about what would be appropriate. I know some group practices just have an automatic clause where they say, if somebody is suing the practice or the physician, then there's a termination proceeding that's immediately initiated. Now, there are other common reasons that include non-payment of bills and refusal to establish and adhere to payment plan. Potential dismissals for financial reasons should be approached cautiously. Also, rude, disruptive, sexually suggestive, profane, violent, or threatening behaviors that endanger other patients or healthcare personnel and dishonesty can be reasons for termination. And I think about some of these situations that whereas typically we were dealing with some of these situations on a face-to-face, in-office basis. Some of you are opening your practices and some of these things can happen in the office, but some of these things may also occur in your virtual relationship or your telemedicine or telehealth relationship when patients are being inappropriate in that encounter, and these same principles, the same principles that apply for face-to-face encounters also apply to telemedicine and telehealth. Attorneys emphasize the importance of documenting in an objective tone such patient behavior and keeping all related correspondence in the patient's medical record. Next slide, please. Now, to avoid allegations of abandonment, why don't we just go through and click all the, there we go, the bullet points, we'll cover those now. Okay, thank you. To avoid allegations of abandonment in the event you need to dismiss a patient, consider taking the following steps. Develop a policy and procedure for appropriately terminating a relationship with patients. As in Mary's case, be sure to resolve or stabilize any acute medical conditions before beginning termination actions. Consult with the managed care plan if applicable. A contractual agreement between the physician and a managed care plan or hospital may require the physician to see any and all enrollees or patients. Provide adequate notification to allow the patient to obtain ongoing medical care. This time period can vary depending upon the situation. Now, that's something that myself and my colleagues we get asked that question asked a lot. What is an adequate time period? Generally speaking, not less than 30 days is adequate notice for a patient to find subsequent care. However, each situation is different and has to be considered on its own merits. A longer time frame, such as 45 to 60 days, may be needed for a patient with no alternative source of care or specialized medical care. Some state statutes or guidelines may require an even longer notice period. Now, unavailable subsequent providers can also be an issue. Just because a patient may have difficulty finding alternative medical care doesn't mean a physician must continue a problematic patient-physician relationship. It would be important for the physician to attempt to establish a therapeutic relationship with the patient, and if that failed, to actively work with the patient to find an alternative source of care. In a situation where there is unavailable subsequent care, liability risk exposure would be high if the physician limited the termination process to give just a 30-day notice. The patient's relationship is with the physician, therefore the physician is ultimately responsible for ending the relationship. Termination decisions, discussions, or letter signing should not be delegated to an office staff member. Next slide, please. So let's discuss the withdrawal care letter and some recommendations. You know, it's very important to use a professional tone that is neither accusatory nor adversarial, even when maybe your patient may be wanting to do that or has been that way with you. Now, this is a sample withdrawal from care letter, and that's included in our website as well. And it just is a nice standard form that can be adapted for individual and use, and also to the specific situation in line. Next slide, please. A specific reason for terminating the relationship need not be stated. If a reason is stated, state in a professional way, and this can be the sample language for reasons. You know, you have consistently failed to follow my advice and recommendations. You have consistently failed to come in for scheduled appointments. You have not followed through with arrangements to pay the balance due on your account. There are significant philosophical differences in our views of medical care and treatment. And again, you know, so often I think the reason, if a reason is provided and it's not always necessary or mandatory, should be brief and concise, because it also, the more detail in the explanation or reason, that seems to prompt some patients to want to then counter that and, you know, write a 10-page letter explaining why they disagree with you. So anyway, and once you've made the, you know, you're starting to make these steps in terms of terminating the relationship, you know, basically the door is closing at this point. So, you know, we're going to move forward from that standpoint. We're not able to salvage the relationship. Next slide, please. Encourage the patient to select a physician promptly and place under his or her care without delay. Give a date that you will no longer be available to provide medical service or prescription refills, allowing the patient reasonable time to find another physician. Be sure the patient has full access to care while choosing another physician. Do not limit your treatment of the patient during this period to urgent or emergency conditions only. Offer assistance in obtaining the names and addresses of local physicians by suggesting the patient contact the local medical society, local hospital referral service, or their healthcare plan or representative. You know, when I've done assessments or I've been talking with physicians, sometimes they have shared with me their termination letter, and they have included in that section where they're trying to refer a patient to another physician, they will specifically name another doctor who may be willing to take on the patient's care. The problem with that is that oftentimes that physician may not be aware that they're being referenced in that letter. If you're having a problem relationship with that patient, you may be passing that problem relationship off to a colleague. And so again, the only time there should be a specific name of a physician is unless, you know, if you've had the opportunity to clear that with that physician and they agree to take on the care of the patient. If the patient has a condition that requires continued medical care, specific instruction may be necessary to ensure that he or she understands continued treatment is necessary and not optional. And if there is a potential for negative consequences or a bad outcome, include this information in the termination letter. Be specific about potential adverse outcomes. So it seems that the real emphasis in the letter is on continued care that may be needed and the care of the patient versus the reason and other factors. If appropriate, refer the patient's failure to comply with a patient contract or medical treatment or payment plan, and offer to forward a copy of the medical record to the new physician upon written request and include a release form for that purpose. Next slide, please. Then you want to copy the patient's primary care physician and any referred physicians and the patient's insurer on the termination letter if appropriate. Send the termination letter by certified mail, return receipt requested, or by US regular mail. If the letter is returned undelivered because the patient refused to sign for it, receipt of the letter by regular mail will serve as notification. Maintain a copy of the termination letter and, if obtained, the signed return receipt acknowledging in the patient's medical record. You know what I always recommend, you know, in addition to the certified letter where you get a receipt that says whether or not the patient accepted the letter, I always say send the letter regular mail as well, because one way or another, they will receive that notification. Next slide, please. Now, I want to touch briefly on immediate termination. If physical threats or violent behavior are the reason for termination, the termination may need to go into effect immediately in order to protect the provider, staff, and other patients. By identifying warning signs that signal violence, you can assist in diffusing unwelcome behaviors and drive the desired outcome. The warning signs listed on the slide can be similar or overlap with one another. Intimidating behavior can be subtle or overwhelming and displayed in various forms. It is commonly directed at clinicians and or their staff through insults, yelling, or hostile posturing. Bullying occurs when repeated aggressive behavior exists. Harassment can be verbal or physical and displayed over a period of time. Sexual harassment can be defined as sexually suggestive comments or physical contact, which can occur once or more. Various triggers or mental instability can contribute to these events, and indications for increased violence may be present through threats, physical altercations, and use of weapons. I have a few recommendations for immediate termination of dangerous patients. Again, you want to create a policy that describes specific patient behaviors that trigger immediate involuntary termination. Train staff and clinicians to recognize behavior that triggers emergency response protocols. Notify law enforcement and obtain a trespass or restraining order as indicated. And it may be, in some cases, you may have to notify staff and evacuate the office for safety, and document events thoroughly and objectively in the medical record. And again, we have to take any kind of threats very seriously in this day and age. Next slide, please. Perhaps unfairly considering the termination steps a physician must take, a patient may end a physician-patient relationship at any time for any reason or for no reason at all. For example, if a patient gets a new job, he or she might want to transfer to a physician whose office is more convenient to their work. The patient may or may not advise you of this choice and request that copies of the medical records be forwarded to the new practice. If the patient clearly conveys a decision to end the relationship, it is advisable to follow up with a letter confirming that the patient has terminated the relationship. Include a statement confirming your understanding that the patient no longer desires to receive medical care through your practice and an effective date. And emphasize the need for follow-up care and include a referral source, for example, the County Medical Society, State Medical Association, or a local hospital or patient's health plan. Include in the medical records release for the patient to complete for records to be sent to subsequent providers. Now, simply relying on the passage of time with no patient contact, for example, a patient that has not been seen for a year does not establish that the relationship has been terminated. In cases of mutual consent or patient request, it is helpful to document this decision in the medical record in addition to any communication with the patient. Next slide, please. Now, there are several scenarios that could play out when a physician is retiring or closing his or her practice. A carefully planned and executed patient notification process is the key to ensuring continuity of care and minimizing liability risk when retiring. Now, in the interest of time, I'm not going to review all the steps for closing your office, but we do have resources available, and there is kind of a standard package of resource documents that are developed by NorCal, as well as the California Medical Association, that are helpful in terms of guiding this process and kind of answering a lot of questions and considerations for retirement. And again, we've worked with many of our policyholders on this issue. Again, next slide, please. Now, however, I do want to mention one thing about closing an office and notification to patients. Often we get questions regarding what constitutes an active patient. And the answer really is that the clinician responsible for the patient's care is in the best position to determine who your active patients are. There are no specific guidelines regarding how to classify a patient as either active or inactive. It varies among practices and specialties. Now, we do have some suggestions to help you decide if a patient is active or inactive. Indicators that a patient may be an active patient include a patient scheduled for follow-up or one that is in your tickler file for follow-up, whether it's weekly, monthly, yearly, or every 5 or 10 years. A patient being prescribed medications can be considered an active patient. Someone receiving any kind of treatment post-op or otherwise, or other follow-up care. And some statutes or regulations define an active patient for notification purposes. Now, within California, I don't know that there is such a statute, but NorCal works with many states throughout the country, and statutes and regulations vary. It's always important to consult with that information. Next slide, please. Now, in closing, withdrawing from a patient relationship can be done appropriately and ethically in a variety of circumstances. Resolve acute medical conditions, give enough notice for the patient to obtain another provider, provide access to medical records. These are important steps. And then follow the risk management recommendations in this webinar. And this may prevent an abandonment claim from being filed against you, or even a complaint to the medical board. Next slide, please. And here's a listing of the resources that are available. I know, don't worry, I think that if I'm not mistaken, the Medical Society will send a copy of the slides to attendees, and that'll include contact information as well as the resources. And please correct me if I'm inaccurate in that statement. And then also, here's some contact information, further information as well. And I'll turn it back over to Richard.
Thanks so much, Brad. We appreciate your insights. And I'm looking at the chat, and I'm not seeing any questions. Actually, my chat is cleared. I don't know if you see any in there, Brad, but if that's it, I think we're good to go.
No, I don't. But again, if there are questions, if folks have questions after the fact, please feel free to contact me or contact the Riverside County Medical Association or the San Bernardino County Medical Association. And if that question needs to be passed on to me, then definitely feel free to contact me and I'll be happy to address it.